Okay, Chapter 18, Part 1, Cardiovascular Emergencies. Let's see what we got going here. So let's talk about a critical topic that affects millions of people, cardiovascular disease, or you might see it referred to as CVD. So when we talk about CVD, we're referring to a group of disorders that impact the heart and the blood vessels. Now, one of the most common types of CVD you'll encounter is coronary heart disease, or as it's referred to as CHD. And that specifically involves the coronary arteries, which supply blood to the heart itself. So think of it this way. If these arteries get clogged or damaged, the heart doesn't get the oxygen and the nutrients that it needs to function properly. So talk about an AMI. Be a big topic within this section. So, that's a critical aspect of coronary heart disease. AMI happens when there's a sudden narrowing or a complete blockage of a coronary artery. Now, this blockage is serious because it leads to the death of the myocardial tissue, which we're talking about, the heart muscle itself. So you can just imagine a garden hose, and if you suddenly pinch it or block it, the water can't flow through. And that's what happens in our coronary arteries without adequate blood flow. The heart can't get the oxygen it needs, and part of it starts to die. Now, interestingly, it's estimated that in the United States, someone experiences an MI about every 40 seconds. So it really highlights the importance of being prepared to recognize and, of course, respond to these conditions. Now, let's discuss cardiac arrest. So that's that critical emergency that, obviously every paramedic needs to understand. So cardiac arrest is essentially the cessation of all cardiac mechanical activity. In simpler terms, it means that the heart has stopped beating effectively, which is confirmed by the absence of any signs of circulation. So obviously this is a life-threatening situation, requires immediate action. Now in the United States, it's interesting to note that most out-of-hospital cardiac arrests happen in a home or a resident. After that, they tend to occur in some public settings and then, of course, in nursing homes. So this information is going to be crucial for us as paramedics because it informs our approach to emergency response. Now let's take a moment to review the anatomy and physiology of the cardiovascular system. And obviously, it's going to be essential for understanding how it all works for our patients. So first, the cardiovascular system is composed of two main components, the heart and the blood vessels. Now you might be wondering, what's the primary function of this system? Well, simply put, it's all about delivering oxygenated blood and nutrients to the cells throughout the body. So you can think of it as a delivery service that ensures every cell gets what it needs to function properly. That's not all though. The cardiovascular system also has some other important roles. For instance, it's responsible for delivering hormones, which are crucial for various body functions. Additionally, it helps transport those waste products from metabolism, like carbon dioxide and other byproducts, away from the cells to recycling or waste disposal sites in the body. So the heart, really a quite incredible organ, and it's structured with 4 chambers that play distinct roles in its function. And let's kind of break those down. You see them listed, but we'll kind of break those down. So here's just another picture of the heart so you can get a good idea of what we're talking about. So let's dive a bit deeper into the roles of the right and left atria in the heart. So the right atrium plays a crucial role in our cardiovascular system. It receives blood that is low in oxygen from several sources, including the superior vena cava, the inferior vena cava, and the coronary sinus. Now think of it as a heart's receiving chamber, welcoming back the blood that's traveled through the body, and it needs to be sent to the lungs for oxygenation. And then we have the left atrium. So that chamber is responsible for receiving freshly oxygenated blood from the lungs via the right and the left pulmonary veins. It's like the heart's waiting room for blood that's just picked up a fresh supply of oxygen. Now, once both atria are filled, they contract simultaneously, pushing that blood through the AV valves into the ventricles. And this coordinated contraction is vital for ensuring that the blood flows efficiently through the heart. Now let's look at the roles of the right and left ventricle. So the right ventricle is responsible for pumping deoxygenated blood to the lungs. So that's where the blood gets rid of carbon dioxide, and it also picks up fresh oxygen. So it's a pretty crucial step in the process of oxygenating our blood so that it can nourish our bodies. And then on the left ventricle, the left ventricle takes on a very important task. It pumps oxygenated blood throughout the entire body. So when the left ventricle contracts, it generates an impulse that you can actually feel at the apex of the heart. That's known as the apical impulse, or the point of maximal impulse. You might see it as a PMI. It's quite fascinating how this physical manifestation indicates that the heart is effectively pumping blood. And then you have a septum, which isn't listed on there, but we'll talk about the septum, and that's the wall that separates the right and the left sides of the heart. The interatrial septum, it separates the right and the left atria, and that ensures the oxygen-poor blood doesn't mix with the oxygen-rich blood. And then the interventricular septum, that separates the right and left ventricles. That separation is crucial for maintaining the efficiency of the heart's pumping action. So that septum in the heart, it plays an important role that we just talked about. So first we have the right atrium and the right ventricle, which together make up one of these pumps. Now that's often referred to as the right heart. It operates as a low pressure system known as the pulmonary circulation. And this means that the blood is sent to the lungs without needing to exert a lot of pressure, allowing for efficient oxygenation. And on the other side, we have the left atrium and the left ventricle, so the left heart. And that composes the other pump, sometimes called, as I mentioned, the left heart. So this side functions as a high pressure pump, and that involves in the systemic circulation. So here the heart must generate enough force to push oxygen-rich blood throughout the entire body, ensuring all the tissues receive the nutrients that they need. So let's take a moment to discuss the myocardium, which is a pretty important part of the heart wall. So the myocardium is that middle layer of the heart wall, and it's primarily composed of thick cardiac muscle tissue. So that's the layer where the real action happens. Now the myocardium is responsible for cardiac contraction, which is essential for pumping blood effectively. So when the muscle fibers of the myocardium contract, they generate the force needed to eject the blood from the heart. So that efficient ejection of blood is crucial for maintaining proper circulation throughout the body. Obviously, without a healthy myocardium, the heart would struggle to perform its primary function of delivering oxygen and nutrients to the tissues. Now let's kind of focus on the coronary arteries, which are responsible for supplying blood to the heart muscle itself. So first thing we'll talk about is the left main coronary artery. It's the largest in diameter and the shortest of the myocardial blood vessels. So it plays an important role in delivering oxygenated blood to the heart. Now the LMCA, or the left main coronary artery, it quickly divides into two important branches. You have the LAD, or the left anterior descending artery, and then you also have the circumflex. Now the region supplied by these arteries can vary among patients. So the LAD typically supplies blood to the anterior surface of the left ventricle, part of its lateral surface, and a portion of the interventricular septum in most patients. And the circumflex artery supplies blood to the left atrium and part of the lateral surface of the left ventricle. Now in about 15% of people, it also supplies the inferior surface of the left ventricle, the posterior surface in another 15%, and the sinoatrial node in about 40%, and then the AV bundle in about 10 to 15%. So there's a few little differences there. Now on the other side, we have the right coronary artery. So the right coronary artery branches supply to the walls of the right atrium and the ventricle, and then a portion of the inferior part of the left ventricle. So parts of the conduction system, specifically the SA node in about 60% of people, and the AV bundle in about 85 to 90% of people. So we have four important properties of cardiac cells. We have automaticity, we have excitability, conductivity, and then contractility. So automaticity, that's the heart's ability to initiate its own electrical impulses without external stimulation. So that means certain cardiac cells, like those in the SA node, can generate action potential spontaneously. And this property is crucial for maintaining the heart's rhythm and then ensuring that it beats consistently. Next, we have excitability, which refers to the ability of the cardiac cells to respond to the stimuli. So when these cells receive an electrical signal, they become depolarized and can initiate a contraction. So this responsiveness is important for coordinating heartbeats and ensuring effective pumping. And then conductivity is the property that allows electrical impulses to travel quickly through the heart muscle. This ensures that the contraction signals spread efficiently from the atria to the ventricles, allowing for a synchronized heartbeat. So that specialized conduction pathway, such as the His-Purkinje system, those all play a key role in this process. And then finally, we have contractility. That's the ability of the cardiac muscle cells to contract and generate force. So this property is essential for pumping blood effectively throughout the body. And strong contractility means that the heart can pump more blood with each beat, which is crucial during times of increased demand, like during exercise and those kind of things. So the cardiac conduction system, it's comprised of 6 different parts. You see them listed. You have the SA node, the AV node, the bundle of His, the right and left bundle branches, and then the Purkinje fibers. So let's talk about the sympathetic and the parasympathetic nervous system and how it influences the heart function. So while the sympathetic nerves are stimulated, several important changes occur in the heart. So stimulation of these nerves increases the strength of cardiac contraction, and this means that the heart can pump more blood with each beat, which is particularly beneficial during stressful situations or physical activity. In addition to enhancing that contraction strength, sympathetic stimulation also raises the heart rate, and that's crucial for responding to those increased demands for oxygen and nutrients, as we mentioned during exercise or in response to stress as well. Now, when the parasympathetic nerves are stimulated, we start to see several key changes occur in the heart. So the stimulation decreases the firing rate of the SA node, which is the heart's natural pacemaker. And then as a result, the heart rate slows down, and that promotes a calmer state in the body. Now, the parasympathetic stimulation also slows down the conduction of electrical impulses through the AV node. And that delay allows more time for the atria to contract and fill the ventricles with blood before they pump it out. Additionally, the strength of atrial contractions is reduced, which can impact the overall efficiency of blood flow into the ventricles. And then lastly, while the primary effect is on the atria, there can also be a slight decrease in the force of ventricular contraction, adding to the overall calming effect on the heart's activity. All right, let's talk about patient assessment. So when it comes to treatment for cardiovascular related symptoms, it's important to recognize that patients can vary widely in age from young adults, actually youth, to older individuals. So here's how we can approach their assessment just systematically. So a patient with cardiovascular symptoms may present at any age, whether they're young, middle-aged, older, and recognizing that diversity is crucial for proper diagnosis and treatment. Now, a systematic approach to patient assessment is essential, especially in emergencies. And there's nothing new here. We go down, we look at our A, B, C, D, E, so our airway, breathing, circulation, disability, and then exposure. Now, however, we have some special considerations for cardiac arrest. So if a patient is found unresponsive and there's a suspicion of cardiac arrest, the order changes to C, A, B, D, E. So we want to start with assessing circulation. So we're checking for pulses, initiating CPR if it's needed. Now, when taking a history for patients presenting with cardiovascular issues, it's crucial to understand acute coronary syndromes, or ACS, which encompasses a range of serious cardiac conditions. Let's kind of talk about what those are. So just talking about a definition of ACS, it refers to a series of cardiac conditions caused by an abrupt reduction in blood flow through a coronary artery. And then that reduced blood flow can lead to significant heart damage if it's not addressed promptly. Now, there's three major types of ACS that people typically encounter, that medics typically encounter. So we have unstable angina, That condition is characterized by chest pain or discomfort that occurs at rest or with minimal exertion. So it may signify that a heart attack could occur soon, making it a critical situation. And then we have a non-ST segment elevation myocardial infarction, or an NSTEMI. That involves a partial blockage of a coronary artery leading to a heart muscle damage. And patients may present with chest pain, but the changes on an ECG may not show the classic ST elevation associated with more severe heart attacks. And then we have what people refer to as a STEMI, or an ST segment elevation myocardial infarction. And that's a more severe form of heart attack where there is a complete blockage of a coronary artery. It typically presents with a significant chest pain and characteristic ST segment elevation on an ECG. And that just indicates extensive heart muscle damage. Now, when we talk about common chief complaints with people that are experiencing ACS, we start to see things like chest discomfort, dyspnea, fainting, palpitations, fatigue. So chest pain or discomfort is often the presenting symptom in a patient with ACS. So the description of discomfort is for assessing its significance. Now, the OPQRS, this is where we start to put in our OPQRST, so our onset, our provocation, quality, region or radiation, severity, and timing. So if the patient has more than one chief complaint, we need to figure out, which started first and then what bothers them the most. So dyspnea is another chief complaint in ACS, and it may vary in intensity. It's really difficult, or it can be difficult to assess because it's a sign and not a symptom. So we want to ask the patient, to rate the severity on a scale of 0 to 10. Now, dyspnea that develops suddenly, it can suggest a PE, so pulmonary embolism, a pneumothorax, acute pulmonary edema, pneumonia, airway obstruction. Now, dyspnea that occurs on exertion or at rest suggests probably more along the lines of COPD or left ventricular failure. And then we talk about orthopnea. That's that type of dyspnea that's relieved by a change in position. And then paroxysmal, so that's a sudden onset of difficulty breathing. So if your patient has a cough, then we need to figure out whether it's dry or if it's productive also when we're talking about these difficulty breathing patients along the lines of cardiac symptoms. So when evaluating a patient who has fainted, it's crucial to determine whether the syncope is due to cardiac or non-cardiac issues. So the distinction can guide some further questions and how you take care of your patient. So let's kind of look at a few more of those in kind of detail here. So some common cardiac causes can arise from several different conditions, including things like dysrhythmias. So abnormal heart rhythms, that can lead to insufficient blood flow to the brain, and that can cause someone to faint. Increased vagal tone, so that can happen in response to stress or certain triggers. That can lead to a sudden drop in heart rate and blood pressure, as well as heart lesions, so structural heart problems such as valve diseases or congenital abnormalities. That can all impair blood flow and result in syncope as well. Now, you might consider it a cardiac cause if the fainting occurs while the patient's in a recumbent position, so that can indicate a serious underlying issue. If fainting happens during physical activity, it could signal a cardiac symptom. The presence of chest pain, obviously, alongside fainting is a strong indicator of potential cardiac issues. Now we see patients with cardiac problems, they may present with a chief complaint of palpitations as well. So there's a number of things that can cause that. Anxiety, a lack of sleep, certain medicines. Big one is caffeine or stress. Cocaine or amphetamine use can do it. Heavy cigarette smoking. There's some metabolic conditions as well. So, we want to ask about the onset and frequency and the duration of this. And then also ask about the presence of associated symptoms such as chest discomfort, dizziness, syncope, dyspnea. So fatigue is a common complaint in patients with impaired cardiovascular functions. So ask when the patient's fatigue began and how long it's been present, and then ask about associated symptoms such as chest discomfort, nausea, dyspnea, things we've been listing, so syncope, palpitations. Now, when assessing patients with potential cardiac issues, it's important to explore a range of related symptoms. So they may report It may describe some symptoms to you, including those feelings of impending doom. I learned to kind of trust those. It doesn't happen every time. However, if they often report this and they could be experiencing a cardiac event, it can indicate a serious condition, and we should be taking it quite seriously. Nausea or vomiting, so those symptoms can accompany cardiac issues, particularly in conditions like an MI, and may be mistaken for some GI problems. If fainting or other symptoms occur following a fall or injury, essential to consider how trauma may contribute to their condition. And then, of course, hypoxia or poor perfusion. So signs of inadequate oxygenation or blood flow, like cyanosis or altered mental status, that can indicate severe underlying problems that require immediate attention. Now, when we start talking about meds, there's a lot of different meds that can affect these things. So we see some stuff listed. So antiarrhythmics, such as digoxin or procainamide or amiodarone, verapamil, anticoagulants. So they could be on Coumadin and Plavix and all these things. ACE inhibitors, so angiotensin converting enzyme inhibitors. Could be something. Beta blockers, obviously. Lipid lowering agents, diuretics. So, what many times people call like a water pill. So it could be lovastatin and, that's a mistake. I'm talking about furosemide, so Lasix or even HCTZ. And then, of course, vasodilators such as nitro or isosorbide. And then there's over-the-counter, some over-the-counter medications. So things like Viagra and Cialis and these kind of things those are non-cardiac medications that we need to think about. And then some herbal supplements and as well as recreational drugs can also cause some concern. Now, you do want to ask about whether they've ever been diagnosed with some things. So aneurysm, atherosclerotic heart disease, angina, definitely if they've had a previous MI. If they have diabetes, inflammatory cardiac disease, all the things that you see listed there, those are good things to ask about. Now, when you're conducting that secondary assessment for a patient with cardiac complaints, it's essential to focus on specific signs and symptoms that may indicate the severity of their condition. So what we're talking about is that physical examination. It should be tailored to assess the cardiac system thoroughly. So this includes, evaluating vital signs, heart sounds, checking for signs of heart failure or other cardiac issues. Of course, skin color and temperature is an important thing. So that can give you ideas about signs of low cardiac output. So they might have pale or mottled skin or cyanotic skin. These changes can indicate poor blood flow, oxygenation issues, and all of these things warrant obviously immediate attention. Now, flushed or warm skin, you see on the last point, if the patient has flushed and warm skin, it may suggest an infectious process, and pericarditis has two sides to it. So it can be just some inflammation or inflammation caused by infection. So this condition can lead to inflammation around the heart, affecting its function and presenting with systemic symptoms as well. Now, when you're performing that physical exam for a patient with cardiac complaints, it's important to follow, as we talk about all the time, just that systematic approach. So you want to inspect the neck and the tracheal position. So you want to begin by inspecting the neck for any abnormalities in the position of the trachea. Midline is normal, while deviation can indicate some underlying issues. You also want to look for some jugular venous pressure assessment. So to estimate that, you can position the patient in a semi-Fowler position, about 30 to 45 degrees, with their head slightly rotated away from the vein that you're assessing. And then you observe the height of the distended fluid column in the jugular vein. That can provide some valuable information about right atrial pressure and the fluid status as well. You want to note how far up the distension extends above the sternal angle. So a height greater than 3 to 4 centimeters can indicate elevated central venous pressure, and that's often seen in heart failure. Then we want to look at the chest. So you want to look for surgical scars that may indicate previous cardiac surgery, such like as bypass grafting or maybe valve replacements. You definitely want to check for a nitro patch on the skin. That can suggest ongoing treatment for angina or heart failure. Inspect for a pacemaker or an implantable defibrillator, and then assess for chest enlargement or that barrel chest, which may be associated with COPD, and that can affect cardiac functions as well. Now, when you're conducting a physical exam for a patient with cardiac concerns, auscultation and abdominal assessment are key components. So let's talk about those points. So as you listen to the patient's lungs, be attentive for crackles or wheezes. Now, those sounds may indicate left ventricular failure with pulmonary edema, which can signify serious heart issues requiring immediate attention. And then with the abdominal inspection, check for distension and pulsations. So an enlarged abdomen or unusual pulsations can provide important clues about the patient's condition. And then strong pulsations in the epigastric area may suggest the presence of a AAA or abdominal aortic aneurysm, which is a critical condition that obviously needs urgent evaluation. And then you look for some swelling as well. So inspect the arms and hands and legs and feet and ankles for any signs of swelling. Bilateral pitting edema could indicate right ventricular failure, and that's suggesting that the heart is not effectively pumping blood, leading to fluid retention. So if pitting edema is limited to one side of the body, that may indicate a blockage in a major vein, such as a DVT or a deep vein thrombosis, which require further investigation as well. And then obviously you've got several of your tools that you need to be utilizing. So cardiac monitor, waveform capnography, and then pulse ox as well. Now, assessing pulse findings, as we're talking about pulse findings in cardiac patients, it's essential for evaluating their cardiac status. So let's go kind of through these, and maybe it's something you might consider. So we want to check for a pulse deficit, which is the difference between the apical pulse, remember that was measured at the heart, and then the peripheral pulse, so felt at the wrist or other locations. A significant deficit may indicate issues such as atrial fib or other forms of arrhythmia, where not all heartbeats are effectively transmitted to the peripheral circulation. And then we want to look at blood pressure management. So it's crucial to measure the patient's blood pressure accurately, pay attention to any abnormal findings, have things like pulsus paradoxus. So that occurs when the systolic blood pressure falls more than 10 millimeters of mercury during inspiration. It can be detected by observing a drop in blood pressure while auscultating the heart sounds. So conditions where that could be present, we could see an MI, cardiogenic shock, a tamponade, or even constrictive pericarditis. And then we could see pulsus alternans. So while checking the pulse, look for a beat-to-beat difference in the strength of the pulse. That phenomenon is known as pulsus alternans, and it can indicate severe ventricular failure, signaling that the heart is struggling to maintain adequate output. Now, when we talk about blood pressure, obviously we want to do a good assessment of blood pressure. It's a critical component of evaluating cardiac patients. So let's kind of just talk about the normal ranges real quick and the elevated, what they may indicate. So a normal systolic blood pressure is defined as less than 120. A normal diastolic is less than 80. And then maintaining these values, pretty important for overall cardiovascular health and function. Now, a systolic of 140 or higher, or a diastolic of 90, that indicates stage 2 hypertension. Considered a little more severe form of high blood pressure. Stage 2 hypertension may require more intensive management, including some meds and obviously lifestyle changes for the patient and all of that. However, the thing to think about is with that stage 2 hypertension, they have the possibility for things like heart disease, stroke, kidney damage. Now, in emergency situations, understanding blood pressure findings can provide some quick insights into a patient's cardiovascular status. So let's kind of look at that. And we mentioned that we're going to talk about how these relate. So causes of elevated blood pressure. So elevated blood pressure may result from anxiety or pain. It's essential to consider the context to interpret these readings accurately. Now, a systolic lower than 90 can indicate hypotension or potentially shock. So it's a critical finding that requires immediate attention as it suggests inadequate perfusion to vital organs. Now, some pulse pressure variation. So a widened pulse pressure may be observed in conditions such as the later stages of shock, where the difference between systolic and diastolic, where it increases. Conversely, narrowed pulse pressure can occur in conditions like tachycardia, cardiac tamponade, where the heart's efficiency in filling may be compromised. And then bilateral blood pressure comparison. So if possible, it's crucial to measure and compare blood pressure in both arms. Significant differences can indicate vascular issues, such as arterial blockage or other underlying conditions. And I think I misspoke a second ago when I talked about widening pulse pressure versus narrowing. If I did, I apologize. Hopefully you already know widened versus narrow pulse pressure. Now let's talk about heart sounds. So that's a part of evaluating cardiac function. So when we talk about like an S1 heart sound, the S1 heart sound occurs near the beginning of the ventricular contraction, wherein the tricuspid and the mitral valves close. So this sound marks the onset of systole. So some factors that affect its intensity: the closing sound of the tricuspid valve, it could be lower in patients with hypertension, indicating an increased pressure within the heart. I'm sorry if I didn't say louder. I think I said louder. I'm already starting to misspeak a bunch. So those S1 sounds can also be louder in patients' conditions like anemia, fever, hyperthyroidism, or even mitral valve stenosis. And then decreased S1 sound intensity can indicate several conditions. So the decreased S sounds, we're talking about fibrotic or calcified mitral valve, so that would impair the valve function. Obesity, just because it's going to muffle the heart tones. Emphysema can affect the heart's position as well as the sound transmission, and then cardiac tamponade as well. So because of that fluid accumulation in that pericardial space, it's going to dampen those heart sounds. And so an abnormal split sound, so a split S1 sound resulting from a delay in the closure of the tricuspid and mitral valve, is considered abnormal. And this finding may suggest conduction delays or other cardiac abnormalities. All right, S2. So let's talk about S2. S2 heart sounds occur near the end of ventricular contraction when the pulmonary and aortic valves close. So that sound marks the onset of diastole. So S2 sounds are often louder in patients with conditions such as high blood pressure, chronic high blood pressure, pulmonary hypertension. So increased pressures can lead to enhanced closure of sounds of these valves. Now, a decrease in S2 sound intensity may be observed in patients with hypotension, where the lower pressures can affect the closure dynamics of the valve. And then a split S2 sound as well. That can occur in the cases of a right bundle branch block, and that results in a delay in the closure of the pulmonic valve. So that can create a noticeable split in the sound. And then carrying on, let's talk about S3. So that's just an extra abnormal heart sound in adults that occurs to ventricular wall vibration. So this sound results from the rapid filling of the ventricle at the beginning of diastole. Now, while S3 is considered normal in children and young adults, in older patients it often indicates some underlying pathology. So S3 is frequently associated with heart failure and can be a sign of volume overload in the ventricles. And it suggests that there's some impaired ventricular function and may warrant further evaluation. And then S4, rare heart sound that occurs just before S1. It's caused by that turbulent filling of a stiff ventricle. So since it's stiff ventricle, it can happen in conditions as ventricular hypertrophy, or it can follow an MI. Now, the presence of S4 sound often indicates that the heart is under increased stress and may be compensating for decreased compliance. So that finding is particularly important when you're assessing patients with known cardiac conditions. So murmurs, what is a murmur? Murmur is a sound that's produced by turbulent blood flow through the heart valves. Now that turbulence can arise from several factors that's related to blood flow dynamics. So increased blood flow across a normal valve. So murmurs can occur when there is an increased blood flow across a normal valve, often seen during periods of high output, such as athletes or even during pregnancy. Now, turbulence may arise from the flow across an irregular or constricted valve, so conditions like aortic stenosis or mitral stenosis, those can lead to characteristic sounds as well. Now, when the blood flows into an enlarged heart chamber, it can create turbulence as well, resulting in a murmur. So it's often seen in conditions like dilated cardiomyopathy. And then murmurs can also be caused by backward blood flow through a compromised valve, and that's known as regurgitation. That can occur in conditions such as mitral valve regurgitation or aortic regurgitation. All right, a lot of importance here about reassessment. Very critical component of effective patient care, especially in cardiac emergencies. So reassessment should be conducted while en route to the hospital, and that ensures any changes in the patient's condition are promptly identified and addressed. It's essential to prepare thorough documentation of the call. That includes history findings, physical exam findings, cardiac monitoring or ECG findings, and then that notification of the receiving facility. So good, clear communication, appropriate information, all of those things are going to be pretty important. Okay, we just got out of the heart sound, so why not jump into cardiac action potential? There's a lot of information here, a lot of things going on, so let's just buckle up. So we'll talk about cardiac action potential. That's a pretty big, kind of a key player in how the heart functions. So it's almost like this little dance of electrical signals that keep our heart beating. So let's talk about how this whole thing breaks down. So phase 0, that's the kind of the exciting start here. So the phase kicks off when our cardiac muscle cell gets an impulse. So think of it as just a starting gun for a race, since we said an exciting start. So we get sodium channels, they swing open, letting sodium flood into the cell, and that makes the inside of the cell positively charged compared to the outside. So the transmembrane potential, it shifts from around negative 90 millivolts to about negative 70 millivolts. Now, when we hit the threshold, even more sodium channels open up, causing a rapid surge of sodium and sending the membrane voltage skyrocketing to about a positive 30 millivolts. And then at the same time, calcium trickles in slowly, which that helps release more calcium from storage, setting the stage for muscle contraction. Now, on an ECG, this phase shows up as the QRS complex, and it's when the heart is getting ready to contract. Then we go to phase 1, so kind of just the calm after the excitement here. So the sodium channels close and the cell starts to cool down a bit. Negatively charged chloride ions enter and some potassium leaves the cell, and that leads to a slight decrease in that transmembrane potential. We get into phase 2, so kind of just that plateau. The phase is all about balance, and it's the longest part of the action potential. So sodium and calcium are still coming into the cell while potassium is leaving. And the presence of calcium keeps the cell in a depolarized state, and that creates that nice plateau. So contraction wraps up when potassium leaves more than sodium and calcium come in. And on the ECG, this phase corresponds to the ST segment. It's like the heart holding its breath for a moment. So that's just that plateau. Then we have phase 3, so kind of time to reset here. So now we're in the final phase of repolarization. So we get that slow calcium channels, they start closing and calcium is pumped out of the cell. Now with potassium channels wide open, then potassium rushes out, and that makes that transmembrane potential more negative again. So by the end of this phase, the membrane potential is back to its resting value, ready to respond to the next signal. And that's represented by the T wave on the ECG. And then phase 4 is just that resting phase, the calm before the next action, when the myocardial cell settles back to its resting membrane potential of about minus 90 millivolts. And that's the cardiac action potential. So the autonomic nervous system and the heart. So we talked a little bit about it before. Let's continue on, get a little deeper. So effects on the heart by the sympathetic and parasympathetic divisions of the autonomic nervous system, what we're going to talk about. So let's take a little closer look at how the sympathetic nervous system acts as the heart's accelerator. So it plays a crucial role in how our heart responds to various demands. The sympathetic nerves specifically supply parts of the heart's electrical system, including the SA node, the AV node, and the ventricular myocardium. So think of these areas as the heart's control center and muscle, all tuned for action. So these nerves transmit commands by releasing norepinephrine, and that neurotransmitter is like a signal to get the heart moving faster. Now, norepinephrine travels to the SA node, which sets the heart's rate. Remember that. The AV node, which helps control the heart's rhythm, and the ventricles, so the heart's pumping chambers. So that norepi goes to all these places. So now when we need to ramp up activity, like during exercise, norepi helps the heart speed up to increase cardiac output. And that's especially important to prevent a buildup of lactic acid in the muscles, which can happen when we're exerting ourselves. Now, an accelerated heart rate means that all phases of the cardiac cycle shorten, and this is like speeding up a movie. Everything happens faster. So with the ventricles having less time to relax between beats, there's also less time for them to fill adequately with blood. So this can lead to a situation where the heart isn't getting enough blood to pump effectively. And if cardiac output decreases because of inadequate filling, signs of myocardial ischemia, remember that's when the heart muscle doesn't get enough blood, those signs can start to appear and it can lead to symptoms like chest pain or discomfort. Now let's shift our focus to parasympathetic nervous system, and that acts as the heart's natural brake. So it plays a crucial role in slowing things down and then promoting relaxation also. So the parasympathetic or inhibitory nerve fibers primarily supply the AV node, the atrial muscle, the AV junction of the heart through the vagus nerve. So think of the vagus nerve as a calming signal. It helps keep our heart rate in check. Now the vagus nerve innervates important functional areas of the heart, and its primary role is to decrease the heart rate. So picture it as a gently pressing the brakes on your heart, allowing it to slow down and recover. Now the vagus nerve can be stimulated in several ways, which helps regulate the heart rate. So when there's increased pressure on the carotid sinus, it sends signals to the vagus nerve to slow the heart rate. Often happens when we're at rest or relaxed. Also the Valsalva maneuver. So another way the vagus nerves get stimulated is through that Valsalva maneuver. And when you strain or exhale forcefully against the closed glottis, so this action can temporarily lower the heart rate, and it's often used in certain medical situations, which we'll be talking about. And then the vagus nerve can also be activated by the distension of hollow organs, like the bladder or the stomach. So when these organs fill up, the vagus nerve signals the heart to slow down, promoting that relaxed state also. All right, we're still talking about the ANS and the heart. So when the brain senses that the heart should ease its pace, it sends an electrical impulse down the vagus nerve to the SA node. And that's like sending a message, as we mentioned, to hit the brakes. Now, as the impulse travels, it stimulates the release of acetylcholine, and that neurotransmitter acts as a signaling molecule telling the heart to start slowing down. So acetylcholine reaches the SA node and signals it to decelerate the heart rate, and this allows the heart to take a breather, kind of just reducing the pace of contractions. That's not all. Another acetylcholine molecule travels to the AV node, ensuring that no additional impulses get through. So this further helps to slow down the heart's rhythm, preventing any rapid firing that can lead to an overly fast heart rate. Now let's dive into some baroreceptors. So these are the body's built-in sensors that help keep our blood pressure in check. So these specialized nerve tissue play an important role in how our body responds to changes in blood pressure. So baroreceptors are often referred to as pressoreceptors because they're sensitive to pressure changes in the blood vessels. So you can find these sensors in key areas like the internal carotid arteries and the aortic arch. And these locations are critical because they monitor blood flow coming from the heart to the brain and the rest of the body. So baroreceptors, they're continuously detecting changes in the blood pressure. So if the blood pressure rises or falls, these sensors quickly pick up on it. And then when they detect changes, baroreceptors generate a reflex response that activates either the sympathetic or the parasympathetic division of that autonomic nervous system. So for example, if the blood pressure drops, then baroreceptors will trigger the sympathetic response to increase the heart rate, constrict blood vessels, help to raise blood pressure back to normal. So let's talk about chemoreceptors. So that's just another set of important sensors in our body that help monitor the chemical composition of our blood. So chemoreceptors are found in the internal carotid arteries, the aortic arch, as well as the medulla of the brain. So these locations are important because they help monitor blood flow and the gas exchange processes happening in our body. Now these receptors, they detect changes in the concentrations of several important substances in the blood. So we see hydrogen ions, and that helps assess the acidity of the blood. O2, so low levels of oxygen can trigger responses to increase oxygen availability. And then CO2, so high carbon dioxide, so high levels of CO2 indicate what the body needs to expel more of it, typically by increasing the breathing rate. Now, when chemoreceptors detect alterations in these chemical levels, they initiate a response that can be either sympathetic or parasympathetic. For instance, if the oxygen levels drop or carbon dioxide levels rise, chemoreceptors can stimulate the sympathetic nervous system to increase the heart rate and respiratory rate, ensuring the body gets more oxygen and expels carbon dioxide effectively. Now, conversely, if everything's balanced, they might promote a parasympathetic response to help calm and just stabilize everything, as we were talking about before. All right, probably seems weird because if you've looked at the PowerPoints, or just not a very good flow. However, we've already, at least the students here at Gordon Cooper, have already gone through EKG. So I took all of those out to not, bore you and just duplicate something that we've already done. So I left in the ones that we need to discuss, and it's lots more about treatment and those type of things. So let's talk about some cardiac dysrhythmias. So those are those irregularities in a heart rhythm, and they can have various causes as well as implications for patient care. So when assessing a cardiac dysrhythmia, it's crucial to evaluate it within the context of the patient's overall clinical condition. So it means looking beyond the numbers on a monitor and considering the whole patient. So you see the words up there, treat the patient, not the monitor. So symptoms such as chest pain, shortness of breath, fatigue, syncope, they can provide some pretty good insight into how the dysrhythmia is affecting the patient. So a key principle in managing these dysrhythmias is to treat the patient and not just the monitor. So what that means is focusing on the patient's symptoms and overall health rather than just solely relying on the rhythm displayed on the ECG. So a patient might have like an irregular heartbeat that doesn't require immediate intervention if they're stable and asymptomatic. But then again, conversely, a patient with a normal rhythm, but they're showing signs of distress, they may need urgent care. So let's talk about symptomatic bradycardia. So when it comes to providing emergency medical care, to obviously timely treatment, it's going to make a big difference in these patient outcomes. So just a quick breakdown kind of all these essential steps as you look at your ACLS card and you go through ACLS. First thing, airway management. We want to make sure that we have an open and effective airway. So we want to make sure we have people on O2, want to put them on a monitor, blood pressure monitor, as well as a pulse ox. We want to get a 12 lead. And then obviously start an IV infusion of normal saline, and then check you a quick little blood glucose test. And if they are hypoglycemic, treat it promptly, help stabilize the patient. And in this particular one, because we're looking at a bradycardia algorithm, if this patient is experiencing symptomatic bradycardia or conduction block, then we want to administer atropine IV bolus. So typical dosing is to repeat atropine every 3 to 5 minutes until the desired heart rate is achieved or until the maximum dosage limit of 3 milligrams has been reached. At first dose, we're talking about, whenever I mention the dose, we're talking about 1 milligram per ACLS. Now let's talk about tachycardia. See rhythms originating in the atria. So we've got the same things, airway, O2, monitor, get you a good blood pressure, pulse ox, 12 lead, IV, and then blood glucose measurement. And then probably when we're talking about a stable patient, so we're talking about narrow QRS tachycardia, adenosine is typically the medication of choice. So, when to administer is if vagal maneuvers have been ineffective and the patient remains stable with that narrow QRS tachycardia. And adenosine is a little tricky in the way that you administer it because it has such a short half-life. So you want to administer adenosine at the IV site closest to the patient's heart. So if you get one in the foot, probably not going to be so pretty good for them. But what this does is it helps ensure rapid delivery to the central circulation. So, obviously you want to use your protocols. However, per ACLS and per AHA, you want to use a recommended dose of adenosine, typically 6 milligrams for the initial dose. If the first dose is ineffective, then a second dose of 12 can be given. Now, one of the big things is you want to follow this with normal saline. So it's immediately followed with a 20 ml flush of normal saline, and that helps to push the medication through the IV line and into the circulation quickly. Now, one thing to think about if you've already forgotten about adenosine is you need to be prepared for asystole. So they could have a short run of asystole. Remember, that's just that temporary absence of heart rhythm following the administration of adenosine. Very common physiological response. So monitor your patient closely during this time, as it can be alarming, but it is typically brief. So if that first dose is unsuccessful, we talked about kind of a double dose. That second dose will be 12. Administer it within 1 to 2 minutes after the first dose. Now, if the rhythm remains unchanged, you can repeat the adenosine dose again in another 1 to 2 minutes, and ensure you continue with that double dose, that 12 milligrams. Now, if after repeated doses, adenosine does not convert the tachycardia, it's crucial to rapidly transport the patient to a medical facility for further evaluation and management. Make sure that they're monitored the whole time. As well as what we're assuming is this patient is staying stable as well. They're not going unstable. Now, because here we're going to talk about unstable. So if at any time the condition of a patient with SVT becomes unstable, so what we mean by that is we have signs of decreased perfusion, altered mental status, hypotension, chest pain, those kinds of things, it's critical to move to the unstable arm of the tachycardia algorithm. So synchronized cardioversion is indicated for the termination of a hemodynamically unstable tachydysrhythmia. And that procedure is essential when the patient's condition is deteriorating and it requires immediate intervention. So, prepare your defibrillator for synchronized cardioversion. Ensure the device is set to synchronize with the patient's R wave. Typically, just one button to push. What that does is by syncing with the R wave, we're hopefully avoiding the inducing of VFib. You want to select your appropriate energy level for cardioversion. That's going to really be based upon your protocols, your local protocols. However, typically it starts at, it can be 50 to 100 joules. And like I said, that depends on the specific protocol. And then make sure you have your safety measures in place. So clear communication to avoid shock delivery during patient movement. So cardioversion is indicated for VTAC as well as SVT when they exhibit that severely compromised cardiac output as we talked about. So if the patient is responsible, that your patient would appreciate it if you sedated them. However, sometimes it is possible, sometimes it's not. But if you're able to sedate them before performing cardioversion, they would definitely appreciate that. So benzos are commonly used for sedation due to their rapid onset and effectiveness. So, lorazepam or midazolam are two good options for that. And then how to perform the cardioversion. As you see up there, you have your skill drill 18.3, which is on the LMS, and that talks about a couple of different things, positioning, the placement of the electrode, setting on the defibrillator, and then of course, safety measures to make sure it's a successful procedure. Now, let's talk about defibrillation. So first things first, when you're dealing with a situation that requires defibrillation, it's super important to keep CPR going while you're getting the defibrillator ready. So think of it this way. Doing CPR keeps blood flowing, which is a crucial element for the patient's chances of survival to increase, especially while you're setting things up. Now, when you're getting ready to use a defibrillator, it's really important to place the pads correctly. So start by positioning one pad on the upper right side of the chest, usually around the clavicle area, just below the collarbone, and then lower side, lower left chest. So next take the other pad, place it on the lower left side of the chest. So you want this pad to be below the heart, typically around the side of the rib cage. That setup helps ensure that the electrical current flows through the heart effectively, maximizing the chances of converting any abnormal rhythms. Now let's talk about the types of waveforms you might encounter with defibrillators. So both AEDs and defibrillators and manual defibrillators deliver energy in different ways. So you may have seen monophasic waveform or biphasic waveform. Let's talk about the differences there. So with monophasic waveform, the energy flows through the heart from one pad to the other in just one direction. So it's straightforward. Sometimes it might not be, though, as effective as other methods. Those other methods is that biphasic waveform. So a bit more advanced. They send energy from one pad to the other and then reverse the direction flowing back through the heart. So many modern defibrillators use this method because it can be more effective in converting certain type of arrhythmias. Now, when you're talking about safety and safety measures for defibrillation, make sure you keep everyone clear. Always double check no one's touching whenever you're about to pop somebody. Avoid pooled water. Never defibrillate a patient who's lying in pooled water. Watch for metal, and if you didn't know it, that pooled water can conduct electricity quite well, so it can be really a big problem for the patient as well as you and your partners. So you want to watch for metal contact. If the patient is touching any metal that others are also in contact with, it's a no-go for defibrillation. You want to avoid creating a pathway for the electrical current that could affect others. And then placement over patches or metal. So be careful not to place a defib pad on any medication patches or metal objects like jewelry. It can cause some pretty bad burns, which your patient does not want. And then implanted devices. So if the patient has an implanted pacemaker or an internal defibrillator, make sure to place the defibrillation pad below the device or consider using an anterior-posterior position for the pads. It helps avoid interference with the implanted device. So let's talk about management of cardiac arrest. So when it comes to handling adult cardiac arrest, some key points to keep in mind. So most patients who experience cardiac arrest usually have some form of prior heart disease. However, it's important to remember that cardiac arrest can also happen due to a variety of other reasons. So things like electrocution, drowning, trauma, drug overdose, asthma, obviously anaphylaxis. Often might not be no warning signs before a cardiac arrest occurs, which makes it all the more critical to be prepared. When I say be prepared, managing cardiac arrest effectively requires an orderly and systematic approach. So it's not just a one-time deal, it's something that needs to be typically kind of just rehearsed repeatedly in a team setting. So practicing together helps everyone know their roles and responsibilities, which can really make a difference when every second counts. So when you first arrive at the scene of cardiac arrest, pretty important that you bring all the right tools with you. I shouldn't have to explain all of these. Defibrillator is obviously going to be important. You need to be able to shock them. O2, airway kit, intubation kit, IV equipment, and your drug box. Those are all going to be important to get all of those. Now, when dealing with a patient in cardiac arrest, there's two main goals that we focus on. So ROSC is one of them, return to spontaneous circulation. So the primary aim is to get the heart beating again. Achieving ROSC means that blood is flowing to the organs, which obviously is crucial for survival. And then there's that preservation of neurological function. So we also want to ensure that once the heart is restarted, the brain and other organs have not suffered significant damage. So preserving neurologic function can make a big difference in the patient's quality of life after the event. So as soon as you discover that a patient is pulseless, it's vital to begin emergency medical care immediately. So time is of the essence in these situations. Quick action can definitely make things a lot better and give you a much better chance of a good outcome. Now, when withholding CPR is appropriate. So while CPR can be a life-saving intervention, there are certain situations where it may be appropriate to withhold it. Rescuer safety, so if attempting to perform CPR puts the rescuers at risk, such as a danger in environment or situation, it's considered appropriate to withhold CPR. So safety is a priority, and we want to ensure that rescuers don't become victims themselves. And then if there are clear clinical signs of irreversible death, like rigor mortis or decapitation or confirmed lethal injuries, CPR is not indicated. So in these cases, the focus should shift to respecting the situation rather than attempting resuscitation. And then, of course, valid advance directives. So if they had a valid advance directive or a physician order for life-sustaining treatment or even a DNR, these documents should be honored. They indicate that the patient's wishes regarding resuscitation and provide clear guidance for rescuers. Now, when you're responding to a cardiac arrest situation, the approach can vary depending on whether or not chest compressions have already been started. So here's how to proceed. Now, remember, this is curriculum. This is not necessarily what you may or may not be doing, so you're going to need to follow your local protocol. Or if you follow state protocol, whatever you do, some of this may apply, some of it may not. Just remember that you're going to need to follow your local protocol. However, if bystanders have already provided uninterrupted chest compressions, or if the cardiac arrest was witnessed by EMS personnel, you can move directly to rhythm analysis. It means you'll check the heart's rhythm using a cardiac monitor to help you know what the next step is. Now, if compressions have not been provided, or the arrest was not witnessed by EMS personnel, we need to start with chest compressions immediately. While you're doing this, a second person should set up the defibrillator. Once the equipment is ready, you can proceed with rhythm analysis. Sorry. So when you're, I think I just hit the same one. Sorry. My gosh, I'm having an issue now. Power went off a minute ago, so I'm having to fire back up, and I'm struggling here. All right, so let's take a look at a couple different rhythms here. So we see four possible cardiac arrest rhythms. So we see pulseless VTAC, we see pulseless VFib, asystole, and PEA. Those are all 4 possible cardiac arrest rhythms. Now, some key points for defibrillation during CPR. If defibrillation is needed, the person doing chest compression should keep going while a second rescuer charges the defibrillator. So that helps maintain blood flow to vital organs. Now, once the defibrillator is charged, it's time to pause CPR. So make sure everyone's clear of the patient and then deliver the shock. And then after delivering the shock, jump right back into chest compressions. Don't pause to check for a rhythm or pulse. Getting back to compressions is going to be really important for keeping that blood circulating. So after about 2 minutes or 5 cycles of CPR, it's time to pause and then check the rhythm on the monitor. So that's going to be pretty crucial for determining the next steps. So if you see a rhythm that's not VFib or VTAC, take a moment to identify what it is and then check for a pulse. So this helps you understand what the patient's condition is a little bit better. Now, if there's no pulse, it's important to move to asystole or the PEA pathway. That means you need to immediately resume CPR. If there is a pulse, if you find a pulse, then obviously that's a good sign. You'll want to follow the appropriate algorithm for whatever new rhythm you've identified. That helps guide your next actions effectively. So to keep everyone fresh and effective, talking about CPR, it's important to switch the CPR compressor and the ventilator after about every 2-minute session. So it helps prevent fatigue and ensures compression stays strong. That's if you're in a bigger system. However, in smaller systems, you may or may not have other people to switch off with. Been there, done that. So when you're delivering CPR, those interruptions should be kept to under 10 seconds. The fewer the interruptions, the more compression that you can deliver, obviously the better for the patient. Keeping those interruptions under 10 seconds according to AHA, as well as research, suggests that's one of the biggest things that we can do, because we're keeping the coronary perfusion pressure up with the continuous CPR. As you mess around for 20, 30, 40 seconds, all that coronary perfusion pressure just goes into the bottom, and you have to spend the next 10 seconds or longer building that coronary perfusion pressure up. So the best thing we can do is really try to shorten down our interruptions, limiting our interruptions. All right, so we're talking about this management of adult cardiac arrest. So get an IV. If you can't get an IV, switch over to IO, reliable alternative, especially in emergencies, you know that. Keep compressions going the whole time. Crucial to achieve vascular access without interrupting chest compressions. So maintaining that blood flow, that's key to keeping the patient not necessarily stable, but in the best spot they can be in. Now in this situation, we're gonna have, once we have an IV or an IO, we're gonna administer epinephrine right away. We're talking about that management of adult cardiac arrest. We're talking about those 4 rhythms. And you're gonna repeat this every 3 to 5 minutes until a pulse returns. And then make sure that you do flush after the epinephrine administration. That helps ensure that that medication reaches that central circulation effectively. Now, refractory VFib or pulsus VTAC. So when these rhythms, when these arrhythmias persist or come back after 1 or more shocks, that's what we're talking about as refractory VFib. So it's a critical situation that needs immediate attention. So one option is amiodarone. It can be very effective in managing refractory VFib or VTAC, and it's often considered in these cases. Another alternative is lidocaine. It can be used if amiodarone isn't suitable or available. Now, one thing you want to make sure you're doing, we're still rolling on with this management of adult cardiac arrest, is we want to look for those identifying reversible causes. So what we're saying is you want to consider your H's and T's. So during a cardiac arrest, it's crucial to think about those H's and T's. These are potential reversible causes like hypoxia, hypovolemia, hyperkalemia, tension pneumo, among others. So recognizing these can really help guide your resuscitation efforts and address any complicating factors. Now you did a really good job, or they were a really good patient, and we achieved ROSC. So if you get ROSC, then you'll want to assess the patient's vitals right away. It's all about ensuring that they're stable or letting them get to stable, hopefully. Supporting airway and breathing is crucial. Sometimes they may need assistance with ventilation. Additionally, administer any meds to manage cardiac dysrhythmia and keep an eye on maintaining the blood pressure. So now let's talk about transportation. So patient typically has the best chance of survival when resuscitation occurs at the scene. So this allows for immediate interventions without the distractions and potential complications of transport. However, if the scene is unsafe, moving to a safer environment might be necessary. It's also important to note that defibrillating a patient in a moving ambulance is not really safe as well. That movement can interfere with the delivery of the shock, and there's also a risk of injury to the patient or the rescuers. So ideally, defibrillation should happen while the ambulance is stationary. Now, there are some special circumstances. So patients with morbid obesity may have unique challenges in airway management as well as CPR effectiveness. So adjusting those techniques and equipment, like using a specialized positioning, it can be crucial. Really hard to do CPR, good compressions. Anaphylaxis, so in cases of cardiac arrest due to anaphylaxis, administering epi quickly is vital. Recognizing the allergic reaction can change the approach to resuscitation. And then opioids. So for cardiac arrest related to opioid overdose, Narcan admin should be considered. This can reverse the effects of opioids and restore breathing. And then in patients with acute asthma, it's important to manage airway obstruction and then consider bronchodilators as part of the resuscitation effort. And then electrolyte disturbances, so like hyperkalemia, hypokalemia, they can lead to specific dysrhythmias. And identifying and treating these electrolyte imbalances is essential for effective resuscitation. And then drowning cases. So it's crucial to focus on airway management, consider hypothermia aspect if that's the case, as patients may respond differently compared to typical cardiac arrests. Now, post-cardiac arrest care. So the goal here is to optimize cardiopulmonary function and ensure vital organ perfusion. That sets the stage for better recovery outcomes. So start by achieving and maintaining an SpO2 of 92% to 98%. Be cautious to avoid hyperventilating them. It can lead to decreased cardiac output and worsen outcomes. And then obtain a 12 lead as soon as possible to check for some acute ST segment elevation, which can indicate some ongoing ischemia or damage. It's crucial to assess and maintain a systolic of at least 90 and a mean of at least 65, and that helps ensure adequate perfusion to vital organs. So if marked hypotension is present, it should be corrected quickly. So administer a fluid bolus of 1 to 2 liters, normal saline or LR, whatever it is that's in your protocols. And if transport time to a medical facility is prolonged and hypotension persists after you have given them some fluid, consider starting a vasopressor to support the blood pressure. Now, if they present with bradycardia or tachycardia, make sure that you follow the appropriate bradycardia or tachycardia algorithm just to manage that rhythm effectively. And then conduct a neuroassessment to determine if the patient can follow commands. This provides some important information about their recovery status, and then of course close monitoring. So closely monitor the post-cardiac arrest patient for any changes in condition. It's going to be pretty important for good care. So decisions about when to continue resuscitative efforts, obviously this should follow local protocols or be made through direct communication with your medical control. Everyone, and I shouldn't say everyone, there are several places that are a little bit different, so make sure that you know how you guys do it. And that ensures that these actions align with the established guidelines. As well as, so if the patient does not respond to pre-hospital cardiac arrest treatments, it may be acceptable to stop CPR for several reasons. So ALS providers can perform an initial resuscitation that's comparable to what would be done in a hospital. If no progress is made, further efforts may not yield additional benefits. Now, CPR performed during patient packaging and transport is generally less effective than one done at the scene, so moving the patient can disrupt compressions and reduce their efficacy. And then EMS providers, they risk physical injury when attempting to perform CPR in a moving ambulance, especially if they are unrestrained, so safety for the team is crucial. And then there's some broader implications. So continuing resuscitation in futile cases can create dangers for other motorists and pedestrians, also ties up resources which delay their availability for other emergencies, and that just complicates care for other people. And then termination of resuscitation efforts. So AHA has established specific criteria for both BLS and ALS termination of resuscitation efforts in adult out-of-hospital cardiac arrests. So these guidelines, they help ensure that decisions are based on evidence as well as best practice. Now, in some jurisdictions, state legislation may be required to allow paramedics to officially pronounce death at the scene. It can vary widely and impacts how everything operates on these scenes, so make sure that you're aware of that. And then there's delicate issues when we're talking about these. So there's family expectations, of what they're expecting that you may or may not do, pressure from bystanders, so they may face some pressure from bystanders or even family members who may not fully understand the situation, so that can make it pretty difficult to make objective decisions. And then for many paramedics, delivering the news of a patient's death can be uncomfortable, so we see some communication challenges. So training in some compassionate communication can help prepare us for these difficult conversations, because those aren't situations, or conversations rather, that anyone really wants to have. But this is one that you probably do want to have. So there we go. That's the end of part 1. And I'll see you guys soon.